Imaging in major trauma. Introduction. Trauma remains a major cause of mortality and morbidity in all age groups. Presented with a multiple injured patient, rapid and effective investigation and treatment are required to maximize the chances of survival and to reduce morbidity. Imaging plays a major role in the assessment and in guiding treatment. As with the clinical assessment, imaging is carried out according to the principle of primary and secondary surveys, identifying major life-threatening injuries of the airway, respiratory system and circulation before a more detailed and typically time-consuming assessment of other injuries. At no point should imaging delay the treatment of immediately life-threatening injuries. As in other settings, the quickest and least invasive examination should be performed first. A radiologist present in the trauma room at the time of patient assessment is able to evaluate the radiographs rapidly, relay this information back to the team and guide further imaging, which may include further plain films, CT, ultrasound and MRI. Plain radiographs. Conventional radiography allows rapid assessment of the major injuries and can be carried out in the trauma room while the patient is clinically assessed and treated. Despite the time constraints, the number of staff involved and the restricted mobility of the patient, high quality images can be routinely obtained with due care and attention. There is no routine set of radiographs to be obtained, and the decision is based on the mechanism of injury, the stability of the patient's condition and whether the patient is intubated. The most commonly performed initial radiographs are a chest radiograph, a single anterior-posterior view of the pelvis and a cervical spine series. The supine chest radiograph should encompass an area from the lung apices to the costophrenic recesses and include the ribs laterally. Chest radiographs give valuable information in both blunt and penetrating trauma. Evaluation of the radiograph should be undertaken in a systemic manner and minimize the chances of missing an injury. In the first instance, the position of line and tubes, including the endotracheal tube, should be assessed, followed by assessment of central airways. Following this, the lungs should be evaluated for abnormal focal areas of opacification, which may represent aspiration, hemorrhage, hematoma or edema, as well as more diffuse opacification reflecting a pleural collection. Alternatively, relative focal or unilateral lucency may reflect a pneumothorax in the supine position. Evaluation of the mediastinum should include its position, which may be altered by tension pneumothoracics or large collection, as well as its contour, and alteration which may reflect a mediastinal hematoma due to aortic or spinal injury. Finally, the skeleton and the soft tissue should be carefully examined for rib, vertebral, scapular and limb fractures, as well as evidence of surgical emphysema and paraspinal hematomas. Figure 14.27, supine chest radiograph of a patient involved in a road traffic accident. The patient is intubated. There are multiple left-sided rib fractures, arrows are shown in the diagram, and extensive surgical emphysema, depression of the left hemidiaphragm and mediastinal shift to the right suggests that there is tension pneumothorax present. In 14.28, retrograde urethrogram in a patient who sustained extensive pelvic fracture following a fall. The pelvic injuries have been stabilized using an external fixation device. The urethrogram identifies extensive injury to the urethra with extravasation of contrast. Pelvic radiographs are also commonly performed to screen for and assess fractures of the bony pelvis. The image should include the iliac crests in their totality and extend inferiorly to below the lesser trochanters. When assessing the film, the alignment of the sacroiliac joints and the symphysis pubis should be carefully examined, as some fractures, especially those of the sacral arcades, can be very subtle on the pelvic radiograph. The presence of pubic fractures raises the possibility of urethral injury and should alert clinicians to exercise caution with bladder catheterization. The utility of cervical spine X-rays depends on the consciousness level of the patient and the presence of distracting injuries. In fully conscious patients with an isolated neck injury, clinical assessment can be used to guide the need for X-rays. In patients with distracting injuries and or altered consciousness, including intubated patients, CT is preferred. Further radiographs of the thoracic and lumbar spine and the peripheral skeleton may be required depending on this clinical setting. As with all skeletal radiographs, two perpendicular views are required for adequate assessment. However, with the increasing use of CT in assessment of the torso, the need for plain films is diminishing. Radiographs of the skull or facial bones have no role in the immediate assessment of the multi-trauma level individual, except for immediate localization of a penetrating object. Ultrasound has an evolving role in the assessment of acutely traumatized patients. The main current roles of ultrasound include the assessment of intraperitoneal fluid and hemopericardium, focused assessment with sonography for trauma, fast the evaluation of pneumothorax in supine patients, and in guiding intervention. This is figure 14.29. There is a lateral view of the cervical spine shown in image A, fails to demonstrate the cervicothoracic junction. In addition, there appears to be a break in the posterior arch of the C1 where the arrow is shown. You can see the posterior break. The image B demonstrates the fracture of the anterior arch as well as the posterior arch of C1. FAST ultrasound is a limited examination directed to look for intraperitoneal fluid or pericardial injury as a marker of underlying injury. This avoids the invasiveness of diagnostic peritoneal lavage. In the presence of free intraperitoneal fluid and an unstable patient, the ultrasound allows the trauma surgeon to explore the abdomen as a cause of blood loss. In the presence of fluid and a hemodynamically stable individual, further assessment by way of CT can be performed. However, it is important to realize that ultrasound has limitations in the identification of free fluid. This includes obscuration of fluid by bowel gas or external surgical emphysema. More organized hematoma may be more difficult to visualize. It must also be emphasized that the principal role of ultrasound is not to identify the primary solid organ injury. Although this may be visualized, occasionally a second ultrasound scan may show free fluid in the presence of an initially negative FAST scan. The detection of a pneumothorax on a supine radiograph can be very difficult. Ultrasound examination may be used to identify a radiographically occult pneumothorax. With a high resolution linear probe, the pleura can be visualized as an echogenic stripe, and its motion with respiration can also be assessed. In the presence of a pneumothorax, the sliding motion of the pleura is lost. Ultrasound may also be used to detect a hemothorax or hemopericardium. Finally, ultrasound may be of value in guiding the placement of an intravascular line by direct visualization of the vessels. This can be especially advantageous in shock patients. Computed tomography (CT) is the main imaging method for investigation of intracranial and intra-abdominal injuries and vertebral fractures. With current multi-detector scanners, a comprehensive examination of the head, spine, chest, abdomen and pelvis can be completed in less than 5 minutes. However, much more time is taken up in transferring the patients and the associated monitoring equipment onto the scanner. Therefore, the total time can be in excess of 30 minutes, and CT should be reserved for individuals whose condition is stable. CT examination of the head is accurate in identifying treatable intracranial injuries and should not be delayed by radiography of peripheral injuries, as there is declining success in cases of intracranial collection when treated after the initial 3 to 4 hours. In comparison, identification of more widespread injuries such as diffuse axonal injury is relatively poor. Examination of facial injuries and cervical spine fractures can also be carried out at the same time, as this only adds seconds to the examination. There is evidence that CT of the abdomen and pelvis is of benefit in multiple trauma when there is a head injury, as it often shows unexpected abnormalities, and this may affect the immediate management, especially if the patient deteriorates. Chest CT with intravenous contrast agent is valuable in identifying vascular and lung injuries and is the most accurate way of demonstrating hemothorax and pneumothorax. The position of chest drains can be identified, allowing adjustment of position if necessary. Abdominal and pelvic CT is usually undertaken as an extension to the chest CT. If an abdominal examination is performed, the pelvis should be included to avoid missing pelvic injuries and free pelvic fluid. CT is an excellent means of identifying hepatic, splenic and renal injuries. Delayed examination after the administration of intravenous contrast agents allows assessment of the pelvic-calyceal system in cases of renal trauma, pancreatic and duodenal injuries, and may also be identified, but detection of these injuries may be more problematic. Using CT, the accuracy of detection of bowel or mesenteric injuries is less than it is for solid organ injury, and these injuries should be suspected when there is free intraperitoneal fluid without an identifiable cause. The image data may be reconstructed into thinner slices for the diagnosis of injuries to the thoracic and lumbar spine and for the better delineation of pelvic and acetabular fractures. Complex intra-articular fractures of the peripheral skeleton, such as calcaneal and tibial plateau fractures, may be usefully examined by dedicated thin sections studies, provided this can not delay the treatment of other more serious injuries. CT angiography may be used to demonstrate vascular injuries in the limbs in those with penetrating injuries or complex displaced fractures. Figure 14.30, computed tomography of the head in a patient with head injury shows bilateral large frontal extradural collections. In this computed tomography of the head following head trauma shows a skull fracture with a large depressed component shown in the figure. We'll see first figure 14.32. Coronal computed tomography image of the body shows a grade 5 splenic injury, shattered spleen. Arrow is shown on the spleen which is shattered, with vascular injury in the hilum and free fluid around spleen and liver. That's the arrowhead. In figure 14.33, coronal CT demonstrating free fluid around the liver. The upper pole of the right kidney and left kidney demonstrates no contrast uptake in keeping with acute vascular injury. In addition, there is distraction injury with lateral dislocation of the T11-12 intervertebral junction. 1434, sagittal reformats of computed tomography of the calcaneus in a patient following a fall illustrate a comminuted calcaneal fracture with intra-articular extension into the posterior facet of the subtalar joint. MRI. The value of immediate MRI in trauma is relatively limited and is largely confined to the imaging of spinal injuries. Access to urgent MRI is not widely available, and there are major practical problems in imaging patients who require ventilation or monitoring. MRI is therefore only practical in stable patients. All monitoring equipments must be MRI compatible, and ventilation support should be undertaken by staff skilled and experienced in these techniques as applied to the MRI environment. MRI may be used to diagnose injuries of the spinal cord and associated perispinal hematomas in patients with neurological signs or symptoms. MRI can supplement CT in spinal injuries by imaging soft tissue injuries to the longitudinal and interspinous ligaments. MRI is mandatory in patients in whom there is facetal dislocation of if surgical reduction is being considered to minimize the risk of displacing soft tissue or disc material into the spinal canal during reduction procedures. Subtle fractures may be difficult to identify, particularly if they are old, but an acute injury is normally identified by the surrounding edema. Bony abnormalities should be reviewed using CT, as fracture lines are hard to identify with MRI and unstable injuries may be overlooked. In the less acute setting, MRI may also be used to assess diffuse axonal injuries with an accuracy exceeding CT. Sagittal T1 weighted A image and T2 weighted B magnetic resonance imaging of the spine demonstrate a burst fracture of L2 causing neural compression. This was figure 14.35. Vascular interventional radiology. With the development and refinement of CT angiography techniques, the diagnostic role of formal angiography has become limited. CT angiography is the first line investigation for aortic trauma and for penetrating and non-penetrating peripheral vascular trauma. Endovascular techniques may play an important role in the treatment of acute solid organ injuries, and the interventional radiologist should be consulted early in the decision-making process using coaxial catheter systems and a variety of available embolic agents such as soluble gelatin sponge and microcoils. Selective embolization and reduction of blood flow to the injured segment can be achieved without causing infarction. Selective embolization techniques are also suitable for the treatment of patients with pelvic fractures with ongoing blood loss and volume issues, with penetrating and non-penetrating extremity trauma. Balloon occlusion and embolization may be employed to control hemorrhage, while the application of stent grafts can aid in re-establishing the circulation to the affected extremity. Imaging in abdominal surgery, acute abdomen. The term acute abdomen encompasses many diverse entities. Imaging in common surgical clinical scenarios. In this section, the roles of different radiological modalities in common surgical scenarios is discussed, with a brief rationale behind their use and typical appearances of various pathological processes. Bowel obstruction. What do we see in bowel obstruction? The plain abdominal radiograph is a useful tool in diagnosing bowel obstruction. Small bowel obstruction can generally be distinguished from large bowel obstruction by virtue of the following. Small bowel lies centrally in the abdomen while large bowel lies peripherally. The valvulae convenientis folds of the small bowel traverse the entire width of the lumen, while the haustora of large bowel do not, and the caliber of the small bowel is typically less than the large even when obstructed. Typically measurements in obstruction, small bowel is 3.5 to 5 cm and large bowel is 5 to 8 cm. However, it must be stressed that a normal plain radiograph does not exclude an obstruction, and if there is persistent concern, further imaging is indicated. CT is the modality of choice, having largely superseded the contrast, follow through or enema, particularly in the acute setting. The key to diagnosis of a mechanical obstruction of either small or large bowel on CT and differentiation from paralytic ileus is identification of a transition zone from dilated proximal bowel to collapsed distal bowel. In small bowel obstruction, if no obvious cause such as a mass, volvulus or interception is identified, then the most likely etiology is additional. There is no need to give oral contrast for a suspected bowel obstruction CT, as fluid in the lumen is a natural contrast agent, and in any case oral contrast may well not reach the point of obstruction by the time of the scan. CT is also invaluable in to diagnose complications of bowel obstruction such as perforation and ischemia. Closed loop obstruction, where the bowel is obstructed at 2 points, often in close proximity to each other and frequently related to an internal hernia or additional band in a particular type of small bowel obstruction prone to developing ischemia, and should be suspected at CT if the bowel is dilated distal to a transition point with a further transition point more distally. Perforation. The erect chest X-ray is the ideal first test for hollow organ perforation, and as little as 10 to 12 ml of free air can be detected under the diaphragm with the following caveats. About 10 minutes should be left between sitting the patient upright to allow air time to rise. The free air must be sought under the right hemidiaphragm to prevent misinterpretation of the gastric air bubble, and the reviewer must be able to recognize Chilaiditi syndrome and the harmless and asymptomatic interposition of large bowel between the diaphragm and liver and diaphragm. Caution must also be exercised in interpreting any free air in the context of recent abdominal surgery, as air can persist for up to 5 to 7 days in the peritoneal cavity. If the erect chest X-ray is equivocal or a possible vault of perforation is suspected, a CT is the optimal modality, which may show tiny quantities of free air but may also show the cause, example peptic ulcer, diverticulitis or a neoplastic lesion. As with suspected obstruction, oral or rectal contrast is unnecessary if perforation is suspected, as making this diagnosis should prompt appropriate management even if the precise site of perforation is not identified. Also, it cannot be overstressed that if there is any possibility of a leak from the gastrointestinal tract, including an anastomotic leak after surgery, then the use of barium is absolutely contraindicated, as it can induce a serious and potentially fatal peritonitis. So this is the figure 14.36, coronal computed tomography showing a failed renal transplant in the right iliac fossa and second transplant in the left iliac fossa. There has also been a right hemicolectomy. There is proximal small bowel obstruction with dilated fluid filled small bowel loops distal to the first point of obstruction, large arrow is shown. There is dilated thick walled fluid filled loops in the pelvis with some adjacent free fluid, which could be followed to a second point of obstruction, the small arrow. The patient was taken to surgery, which confirmed a closed loop obstruction secondary to an adhesive band with ischemia in the segment of small bowel between the points of obstruction. This is a 14.37 erect chest radiograph showing marked bilateral elevation of the hemidiaphragms with a large volume of subdiaphragmatic free gas. 14.38 plain abdominal radiograph showing an abnormal appearance to the gastric wall, which is very clearly visualized due to the presence of gas both inside the lumen and also outside the lumen. This is regular sign of hollow organ perforation, in this case due to duodenal ulcer. Ischemia or infarction. The most useful test when bowel ischemia or infarction is suspected is a CT scan. Intravenous contrast administration is essential to look for thrombus or embolus in the mesenteric vessels, though ischemia due to low flow states can still occur in their absence. Ischemia can be a difficult diagnosis to make radiologically, but is suspected in the appropriate clinical context by bowel wall thickening, submucosal edema and free fluid between the folds of the mesentery, particularly if hemorrhagic. Ischemia must be strongly suspected if these findings are seen in association with a closed loop obstruction or strangulated hernia. Ischemic colitis typically affects the watershed area, which is the junction of the area supplied by the superior and inferior mesenteric arteries, typically in the region of the splenic flexure. When small bowel ischemia proceeds to transmural infarction, the diagnosis is usually more straightforward with evidence of pneumatosis, air in the bowel wall, typically identified. The air in the bowel wall can then track into mesenteric veins and thence to the portal vein. a CT sign of grave prognostic significance in an adult as it implies widespread and relatively long-standing bowel infarction. Gastrointestinal hemorrhage. The etiology of acute gastrointestinal hemorrhage varies between the upper gastrointestinal tract (GIT), common causes including peptic ulcer, varices, and malady tears, and the lower GIT, common causes including angiodysplasia, diverticular hemorrhage, and neoplastic lesions. While endoscopy is a useful first-line investigation for both, in refractory or occult GI hemorrhage, radiology can also contribute to diagnosis and management. Nuclear medicine scans using radioisotope labeled red blood cells are useful when bleeding is intermittent, but for patients suspected of active bleeding, the best investigation is a CT mesenteric angiogram. Non-contrast scans to look for bright blood in the bowel lumen should be supplemented with scans in the arterial phase to assess for a blush due to active extravasation, and portal venous phase to optimize detection of wall thickening and masses, and to look for sites of venous bleeding. If non-invasive imaging is effective, catheter angiography can be used to embolize a bleeding point. Inflammatory process, appendicitis. Historically, a straightforward clinical diagnosis of appendicitis obviated any need for imaging. But with proven accuracy of available modalities, imaging has become increasingly popular to reduce negative appendicectomy rates and to make alternative diagnosis. While a plain radiograph may demonstrate a calcified appendicolith in the right iliac fossa, it is insufficiently sensitive or specific to be reliable. In children, ultrasound is the best test to reduce radiation exposure, and due to typically favorable body habitus, this also applies to females of childbearing age, again to reduce radiation exposure, but also as the symptoms may be mimicked by gynecological pathology such as ectopic pregnancy, hemorrhagic ovarian cyst, and tubo-ovarian abscess. All diagnosis best made with ultrasound. The definitive exclusion of appendicitis, however, hinges on the identification of a normal appendix measuring less than 6 mm diameter. Retrocecal appendicitis can readily escape detection with ultrasound, and thus CT is the next modality of choice, and indeed frequently the first requested in most adults. The diagnosis of appendicitis on CT requires the identification of a thickened appendix more than 7 mm with periappendiceal inflammatory changes as evidenced by stranding in the surrounding fat. Other signs that may be sought include free fluid thickening of the cecal pole, possible localized small bowel ileus, and right iliac fossa lymphadenopathy. Both CT and ultrasound can also identify collections of an inflamed appendix ruptures and can be used to guide percutaneous drainage as a bridge to definitive surgery. Diverticulitis, inflammation of an obstructed diverticulum, typically presents with left iliac fossa pain and pyrexia. While some authors have promoted the use of focused ultrasound for this indication, in general, it is best diagnosed with a CT scan. The typical CT appearance of pericolic inflammatory change around a diverticulum, most commonly in the sigmoid colon. Complications of diverticulitis include perforation, abscess formation, fistulation to adjacent structures, and strictures in the bowel. CT is also the modality of choice to identify these as well, and as with appendicitis, can be used to guide percutaneous abscess drainage as a bridge to definitive surgery. This is 14.39. Acute appendicitis. Contrast enhanced CT scan reconstructed in the coronal plane demonstrates a thickened appendix in the right iliac fossa, arrow is shown, with inflammatory changes in the surrounding fat and reactive thickening of the cecal pole. This figure 14.40. Computed tomographic scan showing a segment of thickened sigmoid colon with a paracolic abscess, the arrow is shown, in a patient with diverticulitis. Moving forward to inflammatory bowel disease. The diagnosis of inflammatory bowel disease is made histologically, though a barium study of the small bowel, either a follow-through where barium is ingested orally or enteroclysis where dilute barium is infused via a nasojejunal tube, is often used as a screening tool if symptoms are vague. If the diagnosis of Crohn's disease is established, barium studies are useful to demonstrate the extent of disease, particularly to demonstrate the length and number of strictures if surgery is planned, although increasingly this role is being superseded by MRI enterography, which entails a abdominopelvic MRI scan after ingestion of an agent such as lactulose or mannitol to distend the small bowel. The other obvious advantage of MRI is the lack of radiation, particularly relevant in young patients with Crohn's disease who often undergo multiple imaging studies over their lifetime, and for this reason it is gaining in popularity for inflammatory bowel disease follow-up. An acute flare-up may also require imaging, and an ultrasound is usually a good first test to look for dilated bowel loops and any abscess, though CT may ultimately be required as gas-filled bowel loops can obscure visualization of an abscess on ultrasound. MRI is the imaging modality of choice to assess perianal fistulae and abscesses. Acute pancreatitis. As with acute appendicitis, when the diagnosis is straightforward clinically, there may be no need for imaging, though increasingly it is used to confirm the diagnosis, to assess the severity of the process and to look for complications. While ultrasound may show gallstones and can demonstrate an enlarged pancreas with peripancreatic fluid and inflammatory changes, the optimal modality is CT. CT performed too early in the course of TAC, example, in the first 12 hours, can be equivocal, and the optimal timing of imaging is 48 to 72 hours. In mild acute pancreatitis, CD may be normal or may show an enlarged edematous gland, but in more severe attacks, other findings should be sought include peripancreatic fluid collections, vascular complications such as arterial pseudoaneurysm formation or venous thrombosis, and necrosis either of the gland itself or of the surrounding fat. Necrosis typically develops 48 to 72 hours after the onset of symptoms and is manifest on CT as lack of enhancement of the necrotic areas. CT with intravenous contrast is therefore essential to look for necrosis, which is potentially catastrophic, particularly if it becomes infected. While CT is not always reliable to diagnose infected necrosis, it is suggested by bubbles of air in the necrotic segment. As with other intra-abdominal inflammatory processes, either ultrasound or more usually CT scan can be used to guide percutaneous drainage of inflammatory fluid collections. Acute cholecystitis or biliary colic or jaundice. While acute cholecystitis is usually due to mechanical obstruction of the cystic duct or gallbladder neck by a gallstone, acute acalculous cholecystitis can occur in critically ill patient from a number of causes. In any case, ultrasound is the modality of choice should this diagnosis be suspected, and the classic diagnostic features are of gallbladder distension with wall thickening more than 3 mm, gallstone obstructing the gallbladder neck or cystic duct may be visualized. Alternatively, in acalculous cholecystitis, sludge may be seen layering in the gallbladder lumen. Associated signs include pericholecystic fluid and hyperemia on Doppler examination. Ultrasonographic Murphy's sign refers to the tenderness over the gallbladder when pressure is applied while scanning and is a supportive finding in making the diagnosis. As a second line investigation, CT is also accurate for this condition, demonstrating similar signs of gallbladder distension and wall thickening with surrounding inflammatory changes. CT is also useful to diagnose complications such as gangrenous cholecystitis, gallbladder perforation, and emphysematous cholecystitis, which may necessitate emergency cholecystectomy. If cross-sectional studies are equivocal, hepatobiliary scintigraphy can be useful with the diagnosis of acute cholecystitis suggested by non-visualization of the gallbladder 3 hours after radioisotope administration. A frequent limitation of ultrasound is failure to visualize the common bile duct through its length due to overlying bowel gas, and elective cholecystectomy was typically accompanied by bile duct exploration to look for duct calculi. Increasingly, however, MRCP has been shown to be highly accurate in excluding bile duct calculi before surgery. Ultrasound is also a useful first-line investigation for jaundice of unknown cause, as it can demonstrate duct dilatation and gallstones. If a definitive cause is not shown with ultrasound or a mass is identified but its precise nature and extent is uncertain, CT is indicated to look for common causes including stones, cholangiocarcinoma, and pancreatic carcinoma. CT can not only identify malignant lesions but can also demonstrate the extent of local infiltration and the presence of metastasis to determine potentially resectability. If the ducts are of normal caliber in a jaundiced patient, liver biopsy should be considered. Renal colic. The historical methods of imaging for renal colic all have their limitations. Plain film radiography may not demonstrate all calculi, will not show renal tract obstruction, and is unreliable for alternative diagnosis. Intravenous urography. IVU necessitates the administration of intravenous contrast, and if a level of obstruction is sought, delayed films up to 8 hours after injection may be required. It also will not provide alternative diagnosis. Ultrasound will demonstrate hydronephrosis and hydroureter and calculi in the kidneys, and either the proximal or distal ureters can usually be identified as echogenic foci with posterior acoustic shadowing. However, the ureter from just below the kidneys to the pelvis is usually obscured by bowel gas, which significantly impairs stone detection. For these reasons, the optimal investigation is now CT-KUB, a non-contrast, low-dose 2 to 3 MSV if megasievert. If a low milliampere scan is performed, equivalent to the dose from a limited IVU series, scan from the upper poles of the kidneys to the pubic symphysis. Contrast administration, either orally or intravenously, is not employed as it does not aid stone detection and may even impair it. Stones are readily identified as high attenuation, typically calcific foci, and the secondary signs of acute ureteric obstruction may also be seen including hydronephrosis and hydroureter, renal enlargement, and perinephric fat standing. The most common sites for stones to be seen are at the areas of ureteric narrowing, namely the periureteric junction, the pelvic brim, and vesicoureteric junction. CT also offers unrivaled capability for making alternative diagnosis when compared with other modalities. Coming to abdominal aortic aneurysm, if pulsatile mass is felt in the abdomen and the diagnosis of a possible abdominal aortic aneurysm is suspected, ultrasound is a useful modality, and provided the aorta is not obscured by bowel gas, an aneurysm can usually reliably be excluded. If, however, ultrasound visualization is suboptimal and the diagnosis is as a result equivocal, or if an aneurysm is identified and information regarding the extent and exact size is required, for example, for surgical or endovascular repair planning, CT angiography is indicated with the aorta typically scanned from the arch of the pubic symphysis in the arterial phase after intravenous contrast. MR angiography is a useful alternative if iodinated contrast is contraindicated. In the case of suspected aneurysm rupture, provided the patient is sufficiently hemodynamically stable to undergo CT angiography should be urgently performed. A supplementary non-enhanced initial scan is used to look for retroperitoneal hematoma, which is typically of relatively high attenuation compared to the blood in the lumen, or a non-contrast scan. Imaging in oncology. Modern surgical treatments of cancer requires an understanding of tumor staging systems, as in many instances the tumor stage will define appropriate management. The development of stage-dependent treatment protocols involving neoadjuvant chemotherapy and preoperative radiotherapy relies on the ability of imaging to determine stage accurately before surgical and pathological staging. Once diagnosis of cancer has been established, often by percutaneous or endoscopic biopsy, new imaging techniques can considerably improve the ability to define the extent of tumor. Although the pathological specimen remains the gold standard, many staging systems are based on the tumor node metastasis classification, the TNM classification. Tumor. The most published studies, cross-sectional imaging techniques, CT, ultrasound, MRI, are more accurate in imaging advanced T3, T4 than early T1, T2 diseases, and the staging of early disease remains a challenge. In gut tumors, endoscopic ultrasound is more accurate than CT or MRI in the local staging of early disease T1 and T2 by virtue of its ability to demonstrate the layered structure of the bowel wall and the depth of tumor penetration. Development in MRI may also improve the staging accuracy of early disease. MRI is extremely valuable in bone and soft tissue tumor staging and in intracranial and spinal disease. Figure 14.41. Echo endoscopy in gastric cancer. The hypoechoic tumors arrows is destroying the layered structure of the gastric wall and extending out beyond the serosa. In the B image, computed tomography scan demonstrates thickening and enhancement of the gastric wall in the same area. The stomach is distended with water to provide low density contrast. Notes. Accurate assessment of nodal involvement remains a challenge for imaging. Most imaging techniques rely purely on size criteria to demonstrate lymph node involvement, with no possibility of identifying macrometastasis in normal sized nodes. A size criterion of 8 to 10 mm is often adopted, but it is not usually possible to distinguish benign reactive nodes from infiltrative nodes. This is a particular problem in patients with intrathoracic neoplasms, in whom enlarged benign reactive mediastinal nodes are common. The echo characteristics of node at endoscopic ultrasound have been used in many centers to increase the accuracy of nodal staging, and nodal sampling is possible via either mediastinoscopy or transesophageal biopsy under endoscopic ultrasound control. PET-CT is of increasing use in detecting nodal metastasis from a wide range of malignancies, with the capacity to co-register the area of increased FDG uptake with a precise anatomical location. Novel MRI contrast agent may help in the identification of non-enlarged tumor infiltrated nodes. Metastasis. The demonstration of metastatic disease will usually significantly affect surgical management. Modern cross-sectional imaging has greatly improved the detection of metastasis, but occult lesions will be overlooked in between 10 and 30% of patients. CT is the most sensitive technique for the detection of lung deposits. Although the decision to perform CT will depend on the site of the primary tumor, its likelihood of intrapulmonary spread and the effect on staging and subsequent therapy of the demonstration of intrapulmonary deposits. Ultrasound and CT are most frequently used to detect liver metastasis. Contrast enhanced CT can detect most lesions greater than 1 centimeter, although accuracy rates vary with the technique used and range from 70% to 90%. Recent studies suggest that MRI may be more accurate than CT in demonstrating the metastatic disease. Preoperative identification of the segment of the liver involved can be determined by translation of the segmental surgical anatomy as defined by Coinod to the cross-sectional CT images. The technique of PET-CT with FDG, an analog of glucose, is becoming a powerful tool in oncological imaging. This functional and anatomical imaging technique reflects tumor metabolism and allows the detection of otherwise occult metastasis. The most common indications for PET or CT have been staging of lymphoma, lung cancer, particularly non-small cell lung cancer, and preoperative assessment of potentially resectable liver metastasis such as colorectal carcinoma metastasis. Intraoperative ultrasound is an additional method of staging that provides superb high-resolution imaging of sub-centimeter liver nodules that may not be palpable at surgery. This is often used immediately prior to resection of liver metastasis. So these are the images. 14.42. A is the surgical lobes of the liver after Coinod, and there is IVC, inferior vena cava, there is left hepatic vein, there is ligamentum teres, there is middle hepatic vein and the right hepatic vein. B diagram. This is the segmental anatomy of computed tomography scan at the level of the hepatic veins, and the lobes are marked and named. There is the 8th lobe shown, the 7th lobe, the 4A and 2. Then C, there is segments of anatomy at the level of the portal veins is shown, which is a lower section in which 4B, 3 and 1, these are the lobes which are identified or seen. Segmental anatomy below the level of portal veins, in this 5, 6 and 1 can be seen. Figure 14.43, positron emission tomography shows fluorodeoxyglucose uptake in a carcinoma of lung, short arrow, and the mediastinal lymph node, there is the long arrow. Thank you.